And now we want to demonstrate the technique of selective cannulation of right and left duct using these hydrophilic guide wires. To get the anatomy a little, because I'm 100% confident that I'm going to cannulate both the ducts, I can inject some contrast. So we are now going to try and pass this wire straight. Can you go now?
It's a very deep cystic duct, and this is a problem in these cases.
So the cystic duct is very low down insertion. So this is sometimes the issue. Can you pass the wire? Yeah, keep going, keep going, keep going, keep going, keep going. So now we are in the main duct. I keep the wire in place, and then I take a balloon. So what we'll do is we'll inflate the balloon right at the bottom so that I can change the direction a little so that the wire can then get into the main duct. Yeah. Now blow the balloon now, and then see if you can now pass the wire. So this straightens the area, and then we'll try and see the wire going in now. So one of the things that we can do at this stage is I can help him by either pushing the balloon very deep in, or
this is good.
Yeah. Excellent, excellent. Fantastic. Next plan is that we want to do a radio frequency ablation, and because this is a 3A lesion, we have to do both sides, left and right. If you dilate the stricture before doing RFA, then you're in a problem, because this catheter is 7 French and the tumor doesn't actually enclose the catheter, which is the principle of this RFA. So this lesion in the left duct is about 3.5 millimeters, so we'll have to do it twice. We place the catheter in the most proximal part, distal part of the stricture, and then we'll switch on this. Usually we set 2 minutes time. The wattage is not very important. We set it at 10, but it's not important. What is important is temperature, and you can see this temperature here. The temperature should be uniformly between 70 to 75. We also did the RFA of the right duct, but there was no need of overlap. Only single segment was sufficient. It was shorter. We then put the left duct stent inside. What we're using is a microvasive wall-flex uncovered stent, 10 centimeters on the left side and 8 centimeters on the right side. I'm putting a gentle pressure on the catheter outside so that I keep pulling back to see that the stent is in right position. You can see the yellow marker, which is the junction between the stent and the catheter. So that has to be constantly kept. Keep coming down. Yep. It's now at the point of no return. See that very nicely on the fluoroscopy. And now I'm going to pull back, pull back, pull back now to completely deploy. And you can see the stent is nicely deployed here. Yep. Okay? So it's now outside. Now what I'm going to do is pull out this whole guide wire and the stent and quickly go in with the right stent. I'm now pushing the stent and hopefully we'll go through. So what I'm going to do is I'm going to use a little screwing movement and push my scope up to see if we can get inside. See this? What I'm doing is I'm pushing my scope up there and then again gently putting pressure on the, and hopefully it will go through. See, now we have gone across. Can you see this? So I just have a few more millimeters to go. Actually open the stent partly, then it tends to slip inside. So if this doesn't happen now, we'll try this trick also. So I'm doing these screwing movements and simultaneously putting pressure on the stent. And if it's not easily going through, then we'll withdraw, come back with a guide wire. We already have a balloon ready with us. So we used a 10 French Sohendra extractor and screwed our way through. Fortunately, this went in. And after the Sohendras went in, we again put in a 6 mm dilator, balloon dilator, and dilated it. And now we have got the stent deep inside. Yeah, can you open flap? The various techniques that have to be sometimes used in these cases, that you are in a difficult situation, and we are glad it happened because it showed several points of illustration of how these problems can be overcome. Okay, yeah, keep completely. You can see now it's opened up completely.
Yes.
Yeah. Okay then.
Perfect. Congratulations to the whole team.
Thank you.
Patient is well treated and well trained.
Thank you.